Welcome to another episode of Keystone Brain Bytes. If you like this channel and you like learning about topics in neurology and clinical neuroscience, then go ahead and hit the like button and subscribe to our YouTube channel, and you'll get these updates whenever we have some time to make them. So today we're going to tackle something that was stimulated by a couple of consultations that I had in the past week. The two consultations involved a couple of things. They involved imaging, specifically MRIs, and they involved pain issues. Now, if you've been a follower for the content that we've created for the past 5 to 7 years or so, then you know that one of the core philosophies that we have is that you are not just the sum of whatever shows up on your MRI. Pain is a super weird and complex thing, and it's not always associated with what we see on the MRI. Sometimes the stuff that we see on an MRI is incidental, and sometimes it's just coincidental with what we see in terms of what you're feeling with pain. So what brings us to this topic is that we had these patients that came in, they both had complaint of lower back pain, and they wanted to know, because they had a scoliosis on a previous imaging study, because they had a MRI that showed a herniated disc, and that previous doctors had told these patients that your back pain is tied to your scoliosis and your back pain is tied to your herniated discs. They wanted to see that if what we did in our practice with NUCA and neuroplasticity could resolve the scoliosis and could resolve the herniated disc problem. And when people come into our office, we are very transparent with them. We try to let them know straight off the bat that when we see you, especially if you're over the age of 18, if you have a scoliosis, we are not going to change it in any significant way. So a patient has a 35 to 40 degree scoliosis, maybe they might see a couple of degrees of improvement from getting their atlas corrected, but we're not going to see something to the range of 15, 20 degree changes in scoliotic curves in most cases. And same thing with herniated disc. If someone has a really large disc herniation, we are probably not going to see that disc herniation change very much during their time in treatment with us. Now, one thing that is important for us though is, would it be meaningful to you if you can have normal functionality, normal movement, and not experience pain, but your scoliosis and your disc herniations are still there? And is that something that you would want to have even if you don't have a resolution of those problems? And this threw the patients in for a little conundrum, because they had gone on for years convinced that their scoliosis and that their herniated disc was the cause of their pain. And this only happens in very rare cases. Only very, very rare cases does a mild to moderate scoliosis actually associated with specific back pain. And only in rare cases, or not rare cases, but only in specific scenarios is our herniated disc related towards back pain. And the cool thing about it is that we could actually help people move and function without pain and still have those issues in there, which means those issues weren't necessarily the cause of the pain. Pain is driven by lots of things. It's multifactorial and it's multidimensional, and it can be handled with multiple different avenues. So when pain is part of the equation, we can look at factors like inflammation and talk about what dietary issues they might be facing that could be exacerbating their pain. We could be talking about different movement patterns and how changing someone's pattern of movement can change their tolerance towards pain. We could also talk about how the central nervous system can actually manifest pain even if there's no actual tissue damage or tissue injury. And by changing the way the brain is perceiving the environment, we could actually change outcomes in terms of pain too. And that's the really great thing about neurology. Actually, it's a double-edged sword, is because sometimes people can be really incapacitated and really disabled because of their pain, even though there's nothing on an MRI that tells them that something is there to point to cut out or try to perform surgery on. But it also opens up avenues to conservative options to change the way the body is perceiving that pain, in the hopes that their body is going to be able to recover, even if the central pathology is still present on the MRI itself. So when it comes to looking at the body as a whole, we have to consider, what are we going to do to change your functionality and not just change the thing that's on the image? because when we get too attached to the image, then you are actually limiting your capacity and your ability to get well, because you are so tied up in your identity for what the image shows, instead of thinking about what's possible in the fact that so many people are able to get substantial improvements in their life despite having herniated disc and despite having things like scoliosis, because that's only one piece of the picture, and we are human beings, which means that there's more to us than just a static image that comes from an MRI. So that's your brain bite for today. Don't be a victim of your imaging, and explore ways to improve function as opposed to just improving the outcomes on an image. Just remember, if you like the content that you're seeing, make sure you hit that like button, make sure you subscribe and share the channel with friends and family and whoever you think might be interested in brain-based content, and we'll see you next time on Brain Bites.